Today we will discuss about the pediatric osteoporosis. So these will be my references, and predominantly what you need to know is that most of uh, data in my slides is from all these references and predominantly from International Society for Clinical Densitometry guidelines. So what is the epidemiology of pediatric osteoporosis? Even around like 50% of children have at least one fracture prior to adulthood. Most frequent site for fracture is the forearm fracture, and it accounts for around 50% of all fractures. And mostly the upper extremity is involved, in which it is like 2/3 of cases do involve the upper extremity, and almost 1/3 of cases do involve the lower extremity. So the lifetime fracture risk between birth and 16 years of age is in males is 40 to 64%, and peak age is at 14 years. In case of females, the lifetime fracture risk is around 30 to 40%, and peak age is at 11 years. So what are the contributing factors? So the metaphysis of long bones are thin and cortical porosity is high, which leads to the transient cortical weakness. There is 8-month delay between the peak growth velocity and peak bone mass accrual. Increased participation in the youth sports. Other genetic factors are also predisposing to it. Around 39% of the total body bone mineral is acquired during the 4 years surrounding the peak in bone accretion. By 4 years following the peak, 95% of the adult bone mass has been achieved. So optimizing the bone accrual during the growth is essential to prevent the current and future fractures. So here we can see that age at peak height velocity in case of girls and in case of boys. So within, like as we have discussed here, that during following 4 years from there, where the age at which the peak bone mass is achieved. In case of boys, they do have their peak height velocity at around 14 years of age, whereas females do have their peak height velocity around 12 or 12 and a half years of age, and they both achieve their peak bone mass almost like 95% fetal mass within these uh, around 4 years later than their this peak height velocity. So how the normal bone accretion occurs? The bone growth occurs through bone deposition and resorption, which allows the bone to expand and lengthen. Bone modeling begins during the fetal life and continues until the epiphyseal fusion. Mechanical loading is essential for the bone modeling. Physical activity is important. Cortical density and structural strength continue to increase into the third decade. How the International Society for Clinical Densitometry has defined the osteoporosis. So pediatric osteoporosis is currently defined by we have to see the Z score, which is equal to less than -2, but it should be associated with a clinically significant fracture history, which is defined as the presence of either 2 or more long bone fractures before the age of 10 years, or 3 or more long bone fractures at any age up to 19 years. Or even so for Z score in isolation could not be taken as a definition for osteoporosis. It should be associated by the clinically significant fracture history. But whereas even one or more vertebral compression fractures occurring without high energy trauma or local disease, irrespective of the BMD Z score. So this is very important. So even if there is a one or more vertebral compression fracture at low trauma levels, so It does not need BMD-Z score to take into account to define the pediatric osteoporosis. So there is always a challenge of underdiagnosing the condition predisposing to osteoporosis, because as we have seen in an earlier slide that we have to wait for the second or third fracture in children with low BMD, or because the BMD-Z score is above -2 despite the recurrent fractures. So diagnosing osteoporosis should not be based on BMD alone, but take into account the clinical context, specifically the severity and the prognosis of the underlying disease or treatment. This is again taken from the ISCD guidelines 2019, which has shown that DEXA is the preferred method for assessing the bone mineral content and areal BMD. In pediatric patients, the posterior anterior spine and total body less head are the preferred sites for the most pediatric subjects. Minimal interval between scans should be 6 to 12 months. Even there have been updates in 2019 which have told that even proximal femur DEXA can be used in children with reduced weight bearing or in those at risk for bone fragility who will need screening into adulthood. Sometimes the stress has also been given on the measurement of 1/3 radius may be used in children who cannot be scanned at other sites. Even lateral distal femur DEXA correlate with fragility fractures risk in the non-ambulatory children. What is primary osteoporosis? So there is a heritable bone fragility which is caused by the intrinsic skeletal defects with abnormal composition of the bone tissue. Causative genes affect the different pathways such as collagen type 1 synthesis, bone mineralization, osteoblast or osteocyte dysfunction. Among them, osteogenesis imperfecta is the most common form of primary osteoporosis, which will lead to the recurrent fractures, skeletal deformities, short stature, blue sclera, dentigenesis imperfecta, hearing loss, ligamentous laxity. This is more of a autosomal dominant, which is type 1 to 5, contributing around 85 to 90% are caused by the COL-A1, COL-A2 and IFITM5 mutations, while rare form shows autosomal recessive or the X-linked inheritance. So we can remember that osteogenesis imperfecta is the most common form of primary osteoporosis. Predominantly, most of them are autosomal dominant, but few can be of autosomal recessive or X-linked inheritance nature. So, broad severity spectrum which ranges from early onset osteoporosis to progressively deforming and perinatal lethal osteogenesis imperfecta. There is dependent on the nature of the type 1 collagen mutation. Type 1 collagen, as we know, is the major component of the bone extracellular matrix and a major determinant of bone strength. Others, like glycine missense mutations causing type 1 collagen structural defects, are very more severe. Milder defects can be because of the other pathological variants that cause the haploinsufficiency. So here we can find the structure in which there is a mature type 1 collagen, and there is a collagen 1 alpha 2 chain, and that is collagen 1 alpha 1 chain. What is idiopathic juvenile osteoporosis? Where the unknown pathophysiology is there, where they will also have pain in the back, hips, and or lower ribs and difficulty walking. Association with vertebral compression fractures and long bone fractures. The onset of symptoms is insidious and usually starts before puberty. So, interestingly, during puberty, the symptoms may improve. There is no positive family history, no extraskeletal manifestations, no growth impairment. That is LRP5 have been described in association in these cases. The diagnosis of idiopathic juvenile osteoporosis remains a clinical one and based on the exclusion of other causes of osteoporosis. What are the causes of secondary osteoporosis? We have to rule out the systemic underlying conditions or medications, inflammatory disorders, hematological or oncological disorders, renal disease, immobility or muscle impairment, medications such as corticosteroids, Other causes like malnutrition, immobilization, lack of physical activity represents additional risk factors for the osteoporosis development. Depending on the underlying cause, the pathophysiology of osteoporosis differs. For example, around 16% of children with acute lymphoblastic leukemia vertebral fractures at diagnosis likely caused by the release of cytokines from the leukemic cells that stimulate the osteoclast activity. The risk of fractures is highest in these cases in the first 2 years. The presence of vertebral fracture at diagnosis is highly predictive of the future fractures. Around 45% of children presenting with vertebral fractures at the diagnosis can be asymptomatic. Therefore, lateral spine imaging do have its very important role to detect the asymptomatic vertebral fractures, predict the risk of future fractures, and prevent the vertebral deformities and long-term morbidity. Immobility is another frequent cause for osteoporosis, and as there is a mechanistic theory which shows that bone strength is regulated by the muscle force. During immobilization, what really happens is that there is a lack of muscle tension, which leads to reduced biochemical bone loading, which is sensed by the osteocytes and translated into the biochemical signals that lead to thinner, long bones and less trabecular bone formation. Hence, children, those with like cerebral palsy who have reduced periosteal apposition in the lower extremity bones, resulting in the reduced cortical thickness. Fractures occur most commonly in the distal femur and the tibia. What is jejunous muscle dystrophy? There is immobility, long-term steroid treatment, and hypogonadism. Intravenous or oral corticosteroids and repeated pulse therapy also may contribute to it. As we have already discussed that leukemia and other malignancy, other infiltrative conditions also needs to be kept in mind, which are associated with low bone density. Low bone density in patients with malignancy is a consequence of poor nutrition, malabsorption, diarrhea, vitamin D deficiency, associated hyperparathyroidism, release of inflammatory cytokines, chronic use of glucocorticoids, the effect of chemotherapy, gonadal failure, and a direct suppressive effect of alkylating agents on bone marrow, and bone toxicity of high dose methotrexate, as well as a direct effect of radiation therapy on the osteoblast. Pediatric acute lymphoblastic leukemia is a known cause of low bone density and osteoporotic fractures. Many studies, among which one study has shown that there is a cumulative fracture incidence of 32% for vertebral fracture and 23% for non-vertebral fractures in children with acute lymphoblastic leukemia over a 6 period, with 39% of children with vertebral fractures being asymptomatic. So vertebral reshaping occurred in the younger children, but persistent vertebral deformity was also noted in about 25%, particularly in the older children and those with more severe vertebral collapse. So how will you see for the workup? Needs to take the thorough medical history needs to be taken, history of fractures, that is number, localization, mechanism, radiographic features must be investigated. Back pain needs to be questioned because it might be a sign of vertebral fractures. Detailed history of other comorbidities, physical activity, diet and medications, growth and puberty status also needs to be checked. Family history to look for that inheritance of some syndromic component like fractures, hearing loss needs to be taken. Anthropometry, including head circumference, body proportions, assessment of teeth, sclera, joint laxity, scoliosis, limb deformities, widening of the wrist and ankles, spine tenderness, skin laxity, and pubertal status needs to be checked. Other parameters like serum calcium phosphate, magnesium, creatinine, alkaline phosphatase, GGT, 25 hydroxy vitamin D, PTH, and urinary creatinine, calcium, and phosphate also needs to be checked. As this we have already discussed that in history we have to take the fracture history in detail, and back pain, the history symptoms suggestive of associated disease like other IBDs, malabsorption, leukemia, and renal failure. This we have already emphasized. Growth and puberty needs to be checked. Family history needs to be taken. Diet is also very important history. Uh, Poor nutrition, intake of calcium and protein also needs to be taken into account. Medications, steroids, physical activities, that is vigorous or equal lack of physical activity do increase the fracture risk. Examination, anthropometry, including the occipitofrontal circumference and body proportions, sclera teeth examination, skin laxity, joint laxity, limb deformities, scoliosis, spine tenderness, pubertal status. To rule out Cushing's disease syndrome is also of importance, and also to look for the thyroid status. So if there is a, we can say that if the fracture is of because of low trauma of tibia, fibula, radius, ulna, fingers, toes and clavicle, it is should trigger in our mind bone health evaluation. So physical and radiographic stigmata also, as we already discussed, these are the stigmata of some syndromic component, that is in case of OI, osteogenesis imperfecta, blue sclera, Wormian bones, joint hypermobility, non-increased risk of fractures such as glucocorticoid exposure, a positive family history of osteoporosis, osteogenesis imperfecta, recurrent low trauma fractures needs to be assessed. Where no secondary cause of osteoporosis can be found, targeted whole exome and RNA sequencing methods should be considered to search for a genetic cause. In rare cases, fracture or bone pain may be the first presenting symptom of an underlying condition. ESR, CBC with leukocyte differentiation, thyroid profile, celiac screening, hypogonadism, and Cushing's disease, as we have already discussed. Diagnostic techniques are the DEXA, conventional lateral spine radiographs, dual energy X-ray absorptiometry, lumbar spine and total body less head are the, as we have already discussed for pediatric osteoporosis, are taken into account. DEXA derived values for children are expressed as age specific and sex specific Z scores. So normative pediatric data must be used for the Z score calculation, which are available for the children older than 3 years for the TBLH, while lumbar spine measurements are feasible and reproducible also for the children aged less than 3 years. Pitfalls in DEXA measurement are common as it is a two-dimensional technique. DEXA measurements underestimate BMD, that is gram per centimeter square, in children with short stature or pubertal delay, and appropriate methods to account for the growth delay when interpreting the DEXA results for the children. So there are actually methods in case of children with short stature or those with pubertal delay, to take these factors into account, and according to that there we can determine the DEXA while taking these factors into account. These are the latest terminologies as per the ISCD 2019 guidelines, in which T score should not appear in pediatric DEXA reports, and the term osteopenia should not appear in the pediatric DEXA reports. The term osteoporosis should not appear in pediatric DEXA reports without a clinically significant fracture history. So low bone mineral mass or bone mineral capacity density is the preferred term for pediatric DEXA reports when bone mineral content or aerial BMD Z scores are less than or equal to -2 st. These things we have already discussed, that what usually happens that we see on our prescription that there is a DEXA, but it is not the right. We should write DXA. We should use a small t rather than a capital T, and not capital Z but instead small z. So these are the latest terminologies. We should remember small t and small z and DXA. These are the latest things we should try to remember always. What are the lab investigations? That thing I think we have already discussed. That is baseline bone metabolism to assess for this. These things has to be done. Others to rule out secondary osteoporosis depending on the clinical, our history examination and case to case approach. ESR, prolactin, thyroid function, malabsorption to rule out malabsorption, celiac disease. Hypogonadism needs to be ruled out, and growth hormone deficiency also needs to be taken into account. Additional investigations depend on the case-to-case basis, in which even serum homocysteine or to rule out homocystinuria, to rule out Cushing syndrome investigations also needs to be done. These are the various types of OI which were proposed in nosology classification of genetic skeletal disorders. OI type 1 is a classic non-deforming OI with persistently blue sclera. OI type 4 is a moderate form of OI in adult, always normal sclera, and OI type 3 there is a progressively deforming osteogenesis imperfecta with normal sclera, and in OI type 5 there is a osteogenesis imperfecta with calcification of the interosseous membranes and or hypertrophic callus, and we should always try to remember that OI type 2 is a perinatally lethal OI. So it is very important to remember. So that blue sclera is predominantly seen in OI type 1 only, whereas perinatally lethal is OI type 2, and which is a progressively deforming OI is a OI type 3 actually. As we have discussed, so lateral spine imaging of thoracic and lumbar vertebra should be performed in all children with suspected osteoporosis, and suspected or like hidden vertebral fractures needs to be investigated. And frequent manifestation of osteoporosis in high risk conditions such as osteogenesis imperfecta and glucocorticoid treated illness. And in those children with motor disabilities, it is seen in around 25% of children. Maybe, as we have discussed, they may be frequently asymptomatic and can go undetected in the absence of trauma. Thoracic region is the most common site in children and adults which is involved. So grading is done by the Gannett's semi-quantitative method based on the estimation of the vertebral height loss and the visual evaluation of the morphological change. A vertebral height loss more than 20% indicates a vertebral fracture, whereas with 20 to 25% height loss defined as mild, whereas 25 to 40% as moderate, and more than 40% as the severe. Newer generation of DEXA scanners can also detect moderate to severe vertebral fractures in children through the vertebral fracture assessment using a lower dose of radiation than the lateral spine radiographs. But we should try to remember that lateral spine radiographs are the gold standard. But DEXA can also do the vertebral imaging, but if it is there is it always doubt that then the gold standard is lateral spine radiographs only. This is the Gannett semi-quantitative classification. So as we can see that there may be wedge deformity, biconcave deformity, or crest deformity, and depending on the percentages we have seen as if more than 20%, that can be categorized depending on 20 to 25 or 25 to 40 or more than 40, we can categorize as mild, moderate, or severe. Quantitative CT and vertebral QCT and peripheral QCT are able to assess the cortical and trabecular bone separately, whereas vertebral bone mineral density rather than aerial BMD may provide information on the bone geometry impossible to obtain with the DEXA. Peripheral QCT devices evaluate the bone at the level of the radius of tibia and can be used as an alternative in children with severe scoliosis that cannot undergo DEXA lumbar spine. Main limitations are related to the need of proper positioning of the patient to achieve the reproducibility, and movement during the scan can result in artifacts. Furthermore, whether peripheral QCT measurements adequately reflect the whole skeleton, including the spine, is under debate. Reference data are available but have their limitations. MRI is not routinely used in clinical practice yet, but represents several advantages. MRI provides volumetric bone measures and can separately evaluate the cortical and trabecular bone like QCT. In children with a history of frequent low impact fractures and unclear cause, a transiliac bone biopsy with tetracycline double labeling may be indicated. Structural and dynamic parameters of bone quality can be obtained through histomorphometry and tissue density assessed using back scattered electron microscopy. But so we actually rarely do bone biopsy for diagnosing pediatric osteoporosis. So up to this point, we should be like in a position to tell that we should always take history in great detail. What are the factors which probably have may predispose to the pediatric osteoporosis that we have already discussed in detail. Then proceed for lab investigations and then imaging to be done. For bone biopsy is like rarely required if we are really in search for some cause we could not find. Children, so this is just a approach. Children presenting with clinically significant fractures, rule out a disorder of mineral metabolism, that is rickets, hypophosphatemia. Assess the dietary intake, supplement use, physical examination to be done, and then investigations as already discussed. If there is a disorder of mineral metabolism suspected, accordingly to that, testing and treatment as needed. If there is no disorder of mineral metabolism nor acute or chronic systemic illness, proceed with the formal osteoporosis evaluation, including imaging as we have already discussed. If this is a primary osteoporosis, look for other factors also, like if there we need to assess to support a congenital heritable form of bone fragility, that is vertebral fractures, skin laxity, blue or gray sclera, Wormian bones, abnormal dentation, long bone deformity, thoracic cage deformity, scoliosis, positive family history. Low BMD also needs to be asked for short stature, muscle weakness. Others like facial dysmorphism, easy bruising, chronic bone pain, joint hypermobility, and positive genetic testing. So this is basically, we will also discuss in further slides also, but this is probably that to look for this that is, as we have discussed, osteogenesis imperfecta in great detail, and also needs to evaluate for an underdiagnosed acute or chronic systemic illness, as we have discussed, that is some malabsorption based on the history, examination, other biochemical workup. If there is we are in suspicion that acute or chronic underlying systemic illness suspected, so it needs to be treated accordingly, and assess for the evidence to support a secondary cause of bone fragility, other disorders like IBD, rheumatic disorders, neuromuscular disease, Richter's muscular dystrophy, cerebral palsy, prolonged immobilization, malignancy, nutritional deprivation. Others needs to be assessed. If there is absence of additional evidence to support a primary or secondary form of bone fragility, refrain from diagnosing the child with osteoporosis unless the child meets the 2013 ISCD fracture criteria. Most of them we have already discussed, or as we have already seen the definition. So in equivocal cases, if there is a no diagnosis despite a comprehensive workup and the child does not demonstrate fulfill these criteria, monitor until the child returns to age appropriate physical activities, including the BMD trajectory. Reevaluate if there are further fractures or unexplained back pain. General measures which need to optimize the bone health are nutrition, vitamin D and calcium. Vitamin D needs to be optimized. Other nutrients also are essential in maintaining the bone health, that is protein, magnesium, zinc, iron, copper, and vitamin C and K. Dietary advice, if there is a suspicion of malabsorption, as we have seen in our last slides, needs to be treated, taken into account and treated accordingly. Exercise and physical activity are also very important, and it should be tailored according to the individual child's capacity, as it promotes the anabolic function in the developing skeleton. Avoid high impact repetitive physical activities. that put additional force on the vertebral column and may cause or exacerbate the existing vertebral fractures. Contact sports should be avoided, and sports with high risk of falls, like skiing and ice skating. Weight bearing exercises and programmed standing exercises may help to maintain or increase the BMD in children with cerebral palsy. High frequency, low amplitude, whole body vibration may produce anabolic bone effects either directly through vibrations transmitted to the skeleton or through indirect neuromuscular effects. Monitoring at risk children. In those at risk of osteoporosis, treatment of the underlying medical condition is central to the prevention of osteoporosis. So this is very important actually. So we should always try to look for the cause actually to treat at risk those children at risk of osteoporosis or those with diagnosed with osteoporosis. Baseline spine radiograph or VFA or DEXA should be considered for children with significant osteoporosis risk fracture, especially those who will be receiving glucocorticoid therapy for at least 3 months. Some recommend 3 months as the threshold, given that the earlier incident vertebral fractures observed after starting glucocorticoids is at 4 months in the pediatric population. Repeat imaging is then performed at 12 months post glucocorticoid initiation. Surveillance with DEXA or VFA or lateral spine radiograph should be performed at least every 1 to 2 years, and if the pathological fractures are detected, then referral for possible treatment is warranted. In boys with Duchenne muscular dystrophy, there is also recommendation for annual BMD screening by DEXA alongside lateral spine imaging based on the clinical suspicion. And as we have discussed that even half of the patients might have asymptomatic vertebral fractures. So bone protective therapy is considered following a vertebral or a low trauma long bone fracture. Addressing pubertal delay from long-term glucocorticoid therapy may additionally promote the skeletal health. So we should not treat pediatric osteoporosis in isolation actually. We should take into account all factors. Other underlying causes needs to be taken into account, and it could not be stressed more that that pubertal delay is also needs to be tackled accordingly. Among the pharmacological intervention, there are many trials. There is a STOP trial. Most of the studies are actually done for the ALL only, in which over 75% of those with vertebral fractures had spontaneous complete reshaping by 6 years following the ALL diagnosis. So why it occurs? Because the child's skeleton is uniquely programmed to allow the spontaneous restoration of the bone mass and reshaping of the fractured vertebral bodies through bone modeling, especially if insults to bone health are only temporary and there is adequate remaining growth potential. So these are the studies actually favoring this. So even like that skeletal recovery can occur following the removal of adverse influence to the bone health, like if we discontinue the glucocorticoids, children there is increased physical activity, improved nutrition is there, less cytokine activation and improved linear growth. In contrast, the bone health insults in Duchenne muscular dystrophy are pervasive, that vertebral body reshaping or improvements in BMD without pharmacological intervention are yet to be described. Early treatment may be considered in adolescents compared to the young children, as adolescents have more limited potential for the natural vertebral body reshaping than the younger children. Anti-resorptive agents like bisphosphonates are very good for the high bone turnover conditions as compared to the low bone turnover conditions, because the low bone turnover conditions are less responsive to the osteoclast targeting bisphosphonates compared to the high bone turnover conditions. Bisphosphonates inactivate the osteoclast activity, causing the separation of the bone turnover. They also have a positive effect on the bone formation despite the reduced overall bone remodeling. Bisphosphonates do prevent the osteoblast and osteocyte apoptosis. Oral bisphosphonates, the data in children is less clear, and risodronate has been used but is less effective in vertebral body reshaping, and its value in reducing the fracture risk is less consistent. Oral bisphosphonates are only those used in those cases only where the intravenous route is unsuitable or in less severe forms of osteogenesis imperfecta. Bisphosphonates. There is no consensus about the ideal drug, frequency, dose, or duration of therapy. Pamindronate has been tried at 0.5 to 1 mg per kg per day over 3 days, every 3 monthly. Zoledronic acid is more potent, cheaper, and requires a shorter infusion time and less frequent administration. It is as effective as pamindronate in improving the lumbar spine BMD-Z scores and fracture rates in OI. Transient hypocalcemia is frequently observed. So normocalcium and adequate vitamin D status prior to the infusion needs to be ensured, together with the calcium supplementation in the immediate post-infusion period. The continuous anti-resorptive action of bisphosphonate arrests the bone remodeling, results in delayed bone repair and healing following the fracture or osteotomies. It may have flu-like syndromes, which may easily be treated by paracetamol. Adequate hydration in the post-infusion period needs to be ensured. There is evidence of demonstrating normal fracture healing time with only slightly delayed osteotomy healing after the bisphosphonate treatment, which may be improved with advancement in medical and surgical management. In those with bisphosphonate treated adults, chronic bone turnover suppression may rarely cause osteonecrosis of jaw and atypical femur fractures. In pediatric cases, there has still been no evidence of osteonecrosis of jaw has been reported. The risk of atypical femur fractures is rare in children, and some experts debate that fractures with atypical features mimicking this are simply due to the underlying bone fragility in children with OI. So there is actually data conflicting, that some data is available in saying that this atypical femur fracture is probably because of bisphosphonate, or it is because of the disease itself, like underlying pathology predisposing to the bone fragility and leading to the atypical femur fracture. So there is a controversy between this thing. For high risk patients with irreversible osteoporosis risk factors, continuation of treatment until final height is attained with a period of active treatment followed by a lower maintenance dose may be beneficial. This typically amounts to at least 2 years, which is the period at which maximal benefit from bisphosphonates has been reported in children with osteogenesis imperfecta. In children with transient osteoporosis risk factors, bisphosphonates may be discontinued if there have been an improvement in the bone assessment, no new fractures in the preceding 12 months, and risk factors are eliminated. Effects of discontinuation more marked in the growing patients than in those who have attained the final height, again supporting the value of continuing the therapy as long as linear growth persists, at least for high-risk children. The potential risk of long-term bisphosphonate use must be weighed against the benefit, and further understanding of the natural history of fracture prediction in various disease cohorts is required before such an approach can be recommended. Denosumab is another, which is a human monoclonal antibody against rank ligand, and there are actually trials so that denosumab significantly increase the lumbar spine aerial BMD as compared to the bisphosphonate therapy. In children, those with OI type 4, traditionally poorly responsive to the bisphosphonates, denosumab reduces the bone resorption markers, improves the vertebral shape, and reduced fracture rate. However, a significant rebound increase in the bone turnover following denosumab discontinuation has led to severe hypercalcemia in several children, requiring the hospitalization. So bisphosphonates have been proposed as a potential solution for use in conjunction with denosumab to prevent this complication. So actually there is a concept of sequential therapy actually. So we will discuss in other seminars about this thing. What are the anabolic agents? Have been tried, not with much success. So among them, the sex hormone therapy has been tried. Other things like also testosterone therapy, delayed puberty may result in BMD increase. So in those boys with Duchenne's muscular dystrophy and delayed puberty, testosterone pubertal induction increase the lumbar spine BMD and improve muscle function. So for girls in the context of hypothalamic amenorrhea, that is in anorexia nervosa and exercise related amenorrhea, the role of estrogen replacement to improve BMD or reduce the fracture risk is less clear. So actually the data is less clear about this testosterone and estrogen therapy. But low dose estrogen, oral contraceptive and dihydroepiandrosterone may improve the bone strength and BMD in some older adolescents with anorexia nervosa, but these are not the primary modalities of treatment. So in those cases in which there is a delayed puberty, we want to use testosterone, like in cases of CDGP, or in case of those females for the proper pubertal development, if we are using estrogen replacement, then that is okay. But primarily for the purpose of pediatric osteoporosis, these are not the primary modalities, as we have already discussed that bisphosphonates, denosumab are okay and good enough for this, and these needs to be maybe used, but in a scenario where primarily we are not targeting the pediatric osteoporosis, rather other things also we are taking into account. There have been studies which have shown the physiological estrogen replacement which have increased the BMD in girls with anorexia nervosa, but the best way to improve BMD is by regaining the weight and restoring the menses. We know that is female athlete tried in case of adults and girl athletes. So oral contraceptives in amenorrheic athletes more than 16-year-old may be considered if BMD is falling even after adequate weight gain. This has been recommended by the American College of Sports Medicine. Teriparatide is another drug which has been tried, which is a parathyroid hormone analog. First anabolic therapy approved for use in adults with osteoporosis. There is some preclinical studies in rats which have raised the concerns about it of osteosarcoma. Small trials in 6 Duchenne's muscular dystrophy patients on long-term glucocorticoids and with severe osteoporosis, despite bisphosphonate therapy, were treated with teriparatide with favorable results. Teriparatide, the research is going on this field. US FDA has recently removed the black box of osteosarcoma risk and dosing limitations to 24 months of use, following a conclusion that osteosarcoma risk was only confined to the animal studies. It is also a promising treatment option. Trials in children with osteoporosis are likely going on. Growth hormone. Isolated use of growth hormone for the purpose of pediatric osteoporosis is not recommended, but like those children who have growth hormone deficiency, or like for short stature treatment, there is obviously a recommendation, but it also do in studies, in such studies have shown that it increases the bone cortical thickness and improve the muscle mass. It actually acts on the growth plate cartilage, leading to endochondral bone formation and longitudinal growth. Growth hormone treatment in children with growth hormone deficiency increases the bone mineral content and bone strength through the bone geometry changes rather than BMD. GH therapy has been evaluated in non-growth hormone deficiency childhood osteoporosis. It resulted only in modest improvement in the bone outcomes, as that we have discussed, that it needs not to be used for the isolated pediatric osteoporosis. Overall evidence of GH as an anabolic therapy for non-GHD childhood osteoporosis remains weak. Other animal studies of anti-DKK1 monoclonal antibody accelerates the bone formation and increase the BMD, but human studies are awaited. Other studies on drugs like freselimumab, that is anti-TGF beta therapy, is also under clinical trials. Losartan is also in clinical trials, and other phase 1 trial on romosozumab in children with OI is also going on. What is glucocorticoid induced osteoporosis? There is a trial that we have already discussed in one of the slides, that is for ALL children. There is a trial which is steroid associated osteoporosis in pediatric population trial. There is a 6-year multi-center observational cohort study in glucocorticoid treated children. Vertebral fractures are the hallmark of pediatric glucocorticoid-induced osteoporosis. It occurs early in the treatment course, often asymptomatic even when severe. Have been diagnosed as early as 4 to 6 months following the glucocorticoid initiation in children with rheumatic disease and Duchenne muscular dystrophy. Peak incidence at 1 year of treatment. This is probably because of these factors that it affects at multiple sites. The glucocorticoids decrease the chondrocyte growth plate activity. There is a increased osteoclast bone resorption, probably because of decreased osteoprotogerin and increased rank ligand. There is, as we can see, that there is a osteocyte and mechanosensing is decreased, and also the growth factors, sex steroids, WNT signaling is decreased, further leading to decrease in the osteoblast bone formation. Others are the decreased intestinal calcium absorption, decreased renal calcium absorption. So these are the factors which ultimately lead to the decreased osteocyte-mediated mechanosensing, impaired bone formation, accelerated the bone resorption in the early phases of glucocorticoid exposure, increased 25-hydroxyvitamin D catabolism, decreased intestinal calcium absorption, increased renal calcium excretion, interfere with lowering of the mechanostat set point by estrogen in girls with delayed puberty. So approach is that how to approach. So basically, when there is a more than 3 monthly of daily oral or intermittent intravenous of glucocorticoid therapy at supraphysiological doses, that is 8 to 10 milligram per meter square per day in hydrocortisone equivalents. Optimize the adequate calcium and vitamin D intake. Underlying disease also obviously needs to be treated. Increase the mobility, a healthy weight, and reporting of back pain. Investigate and treat the delayed growth and puberty. Lateral spine imaging at the baseline and annually. Monitor the changes in BMI every 3 to 6 months. BMD at baseline and 12 months need to be done. Consider a bone mineral density at 6 months if the patient develops Cushingoid features, including increase in BMI Z scores. Consider lateral spine imaging sooner if there is a back pain or if there is more than 0.5 decline in BMD Z scores on 2 consecutive measurements. Early signs of vertebral fractures, that is more than 20% loss of vertebral height ratio, loss of end plate parallelism, end plate interruption, or anterior cortical buckling is there, or if there is a low trauma long bone fracture. If it is there, then that needs to be whether the child needs bisphosphonate therapy or not, or will there be reconstitution of normal vertebral dimensions, that is vertebral body reshaping by itself. So there are multiple factors to consider whether we should give the treatment to such children, or should we like keep under observation, keep good nutrition, calcium, vitamin D intake. There is a always a less probability of self kind of reshaping if there is more than 3 month exposure to steroids, if subnormal mobility is likely to be there, if poorly controlled underlying disease, if child is of older age, less residual growth potential, more severe collapse, that is higher fracture grade, or treat in that condition we have to obviously treat with intravenous bisphosphonates. Sometimes there is a good potential for the bone to recover by itself, that is less than 3 months of steroids, short term immobilization of less than 2 weeks, well controlled underlying disease. If child is young, more residual growth potential is obviously will be there, milder collapse of lower fracture grade, and in that condition we may continue to monitor. But if the child remains on steroids following steroid cessation, if osteoporosis risk factors persist like subnormal mobility, in case of Duchenne muscular dystrophy, poorly controlled underlying disease, monitoring is sufficient, like annual spine imaging and BMD. Spine imaging should be done sooner if there is a back pain, as we have discussed, or if there is a decline of BMD Z score of more than or equal to 0.5 in 2 consecutive measurements. If there is an early sign of vertebral collapse, taking vertebral height into account, and these other factors also needs to be taken into account. And if it is not, then continue to monitor. BMD Z scores appropriate for height, normalization of bone mineral accrual rates appropriate for the age, bone age, and gender, reshaping of vertebral bodies following vertebral fractures, absence of new low trauma, vertebral and non-vertebral fractures. The treatment of bone fragility in children with glucocorticoid osteoporosis, that thing we have already discussed. That is, when there is a more potential, once we start with intravenous bisphosphonate therapy. So initiating doses, there is actually no consensus at what dose we should start, but it is used at frequent intervals, usually of 3 months, every 3 month duration, and then every 6 monthly the doses of zoledronic acid are usually used. As these factors we already discussed, that when there is a less potential for the self reshaping of vertebral fracture or coming to shape by itself, there is a lesser potential. These factors we have already discussed, like older age and or if younger age, but persistence of these factors is there. So but in some cases, like in children, intravenous bisphosphonate therapy may still be indicated in younger children with bone fragility but without persistent risk factors if the fractures significantly impact the young child's quality of life, that is back pain due to vertebral fractures. Monitor on treatment to ensure the stabilization of osteoporosis, which is defined as absence of new vertebral fractures on annual spine imaging, reshaping of previous fractured vertebral bodies, and absence of back pain, absence of new long bone fractures, restoration of the normal mobility, normalization of the BMD Z scores for height, and bone mineral accrual rates for age and bone age and gender also needs to be checked. Reduce the bisphosphonate therapy to maintenance dose for as long as risk factors persist for an additional year following glucocorticoid cessation in children with open epiphysis. Continue bisphosphonate therapy at initiation doses. Consider increasing to the maximal annual initiation dose if bone fragility is ongoing, provided the maximum dose has not yet been reached. So these are the doses of pamindronate and zoledronic acid divided into 2 treatment cycles. One cycle is given every 6 months, and along with that, after that phase, maintenance therapies doses are also given, and these are the doses. So intravenous bisphosphonate therapy for children less than 2 years of age, a rare event in pediatric glucocorticoid induced osteoporosis, is administered more frequently. In case of pamindronate is given every 2 months. Zoledronic acid, as we have discussed, is given every 3 months, same as maximal annual initiation and maintenance doses as for the adult children, but the frequency is like much more in case of younger children. So this is a current standard of care for those boys with Duchenne's muscular dystrophy. So during the monitoring phase, there is a vertebral fracture and BMD surveillance is done. If the treatment initiation and during stabilization phase, if IV bisphosphonate therapy is used at initiation doses, once there is early signs of fracture is there, and in the maintenance, these needs to be continued at the maintenance doses. And also, as we have discussed, that testosterone can be used for the pubertal induction. So regarding the summary, so we have already discussed about the criteria for the diagnosis of osteoporosis in children, that is low trauma vertebral fracture alone or low BMD for age combined with multiple low trauma long bone fractures, that we have already discussed in great detail. So vertebral fractures can be asymptomatic and can occur in children with even with normal BMD. So always have a high index of suspicion and screen at risk patients. Reshaping of vertebral fractures and restoration of bone density. can occur spontaneously but is more common in younger children with mild disease and transient risk factors. Pharmacotherapy is indicated for children with primary osteoporosis and those who are unlikely to have spontaneous recovery. Thank you.